Welcome to the Melanoma Research Foundation's Ask the Expert series. My name is Debbie Churgai. I'm the Education Program Manager at the Melanoma Research Foundation. We are pleased to have you join us today for this wonderful educational opportunity entitled TIL Cell Therapy, a review of the newest FDA-approved drug for advanced melanoma. Today, we will be taking a deep dive look into TIL cell therapy, the newest groundbreaking treatment for advanced melanoma. During the webinar, patients and caregivers will learn about the efficacy, durability, process, and time frame of this new FDA-approved treatment, and you will get the chance to hear from both a physician and a patient. Before I get started, I just want to give you want to share a little bit about the MRF. Our mission is to eradicate melanoma by accelerating research while educating to and advocating for the melanoma community. We know that education is critical for patients to make informed decisions about their care, and we are grateful to Iovance Biotherapeutics for their generous support of this webinar series and investment in MRF's mission. Just a bit of housekeeping before we get started. We encourage you to use the Q&A box that you'll see at the bottom of your screen to ask questions, and you can ask them throughout the session. We will wait till the end of the session to go into the Q&A, but you can ask them anytime. The information presented during today's session is for educational purposes, and any individual treatment questions should be directed to your healthcare provider. We encourage everyone to visit melanoma.org to learn more about our resources that we have available. And also this session will be available for viewing later as part of our videos on demand library that you can share with others. I would like to first introduce Vanita Sharma, Executive Director of External Engagement Strategy at Iovance.
Thank you. Hello, it's with great privilege that I have the honor of introducing Dr. Allison Badoff-Warner to the Melanoma Research Foundation's Ask the Expert webinar. Dr. Allison Badoff-Warner is the Director of the Melanoma Program, Director of Solid Tumor Cellular Therapy, and the Mark and Mary Stevens Endowed Scholar in Melanoma at Stanford Cancer Institute. Dr. Badoff-Warner completed her MD and PhD at Duke University, her internal medicine residency at Massachusetts General Hospital, and medical oncology fellowship at Memorial Sloan Kettering Cancer Center. Dr. Badoff-Warner's laboratory focuses on understanding resistance to immune checkpoint blockade and cellular therapies for melanoma and other solid tumors. She is a principal investigator of clinical trials exploring novel treatments for immunotherapy refractory melanoma, and is internationally recognized for her expertise in brain metastasis and the use of novel cellular therapies. Dr. Badoff-Warner has been a pioneer in the use of commercial T-cell immunotherapy for the treatment of melanoma and other solid tumors. She has received funding and awards for her clinical and translational investigative work from multiple high-profile organizations, including the American Society of Clinical Oncology, or ASCO, the National Institutes of Health, or NIH, and of course, the Melanoma Research Foundation. It's a great honor that I introduce Dr. Allison Badoff-Warner.
All right. It is a pleasure to be here, and thank you to the MRF and to Vanita. Thank you for the really warm introduction. I'm delighted to be with all of you today and to share some updates on, as you heard, the best and the brightest and the newest treatment for advanced melanoma. So with that, I'm just going to dive in. So let's just start by talking about what the TIL process is. So TIL is tumor infiltrating lymphocyte, and this is essentially a living drug, right? We take cells out of a patient, expand their T cells, and then get the patient ready, and then give back those T cells that have the ability to fight melanoma. And so a bit of an overview of the process. So patients undergo a surgery. As of right now, this still does require a surgery. This cannot be done by a biopsy, and it needs to be done fresh when we are ready to actually make the TIL. So we cannot use old tissue for a patient. So patients undergo a surgery to take out somewhere between 1.5 and 4 centimeters of tumor. And in the operating room, the surgeon cuts apart that tumor, gets rid of as much dead tissue and non-tumor tissue, and then that is packaged and sent by courier to Iovance for processing. That production period, then the company then divides up and splits up that tumor very small, gets rid of the tumor cells, and tries to grow up and expand those T cells that are active against the melanoma. The expansion process and testing process of those cells takes a total of about 35 days. And during that period of time, patients are just recovering from their operation and going about their normal life. There's no active treatment, though patients can get what is called bridging therapy if needed. So either a systemic therapy or something like radiation therapy if there's a particular portion of a tumor that is causing a problem. During that TIL production period, those cells expand and then are tested for infection, for viability of the cells, and to make sure that they are active. And then they're frozen and shipped back to the treatment center. Upon receipt of those cells, that's when the process really begins in more detail for the patient. So patients then get a period of what is called lymphodepleting chemotherapy. So that's 2 different chemotherapy medicines, and that chemotherapy is not aimed at killing the melanoma, but is instead meant to get the patient's immune system ready to receive those TIL cells. So that gets rid of any cells that would compete with the TIL cells, as well as any immune suppressive cells or signaling molecules that are present in the patient. That period of chemotherapy is about 5 to 7 days, depending on how that treatment center gives that chemotherapy. That can be done as an outpatient at certain centers or during a hospital admission at other centers. And then the next day, the patients get the TIL cells. Those TIL cells are infused in a large IV line, a port, or some type of large semi-permanent IV. And that is followed either 3 hours or up to 24 hours later by up to 6 doses of high-dose IL-2. And IL-2 used to be given as a medicine itself for melanoma, but at this point, IL-2 is used as part of this regimen as a supportive medicine to help keep those T cells alive and to tell them to be active and to proliferate and to take up residence in the patient's body. I mentioned that patients get somewhere between 1 and 6 doses, and that's really because we do this dosing depending on how the patient tolerates it. So some patients will have very few side effects with IL-2, but more commonly, we see fevers and chills and sometimes some organ dysfunction that I'll go into in a moment that can change the number of doses of IL-2 that a patient may get. After that IL-2 administration, we are simply waiting for the patient to really recover from the process. So that's for the blood counts to come back from the chemotherapy, as well as for any IL-2 side effects to resolve. Patients are typically in the hospital, leaving out the chemotherapy, which is sometimes done as an outpatient and sometimes done as an inpatient. But from the day of cells, to the day of discharge from the hospital, that's typically somewhere in the 10-day to 2-week range, though there's wide variability based on the patients and how they do. Most centers will require that patients are within 1 hour of the treatment center with a full-time caregiver for 30 days from the day that the cells are administered. And that is really a recommendation based on how other cell therapies are given for patient safety and to make sure that we can have really close follow-up with the patient. After that time, patients essentially get that treatment 1 time only. This is a one-shot deal, and then are in follow-up and scan follow-up. And we'll talk briefly in a moment about what the responses are to TIL therapy. But overall, it's really that period of 30 days that is the really, intense period of time. And then it is, as I said, a one-time treatment that patients then just go into follow-up with their treatment center and their physician. So let's talk about the efficacy of this approach. So the approval for lifileucel was based on the C-144-01 study. And this study looked at patients with melanoma that had progressed on standard immunotherapy, so a PD-1 containing regimen. And if patients had a mutation in the BRAF gene, then they were required to also have had targeted therapy, BRAF plus or minus MEK inhibitors, as is standard of care for melanoma. So what you're looking at here is a waterfall plot, and some of you may be more familiar with seeing this, but for those of us that aren't, right, lines that go downward from this baseline means tumors shrunk. And there's this dotted line shown at the minus 30 or 30% change. And below that means tumors shrunk more than 30%. And we are looking for that to call this a true response to treatment. So you can see here green bars, which show a complete response. And that means all of the measurable tumor on the scans went away. But there's a large proportion of patients here who were between that 30% shrinkage and 100% shrinkage, who also have what we call a partial response to treatment. Then there are patients who have what we call stable disease, meaning essentially they did not meet that bar of 30% shrinkage, but also did not, have significant growth of their tumor. And then, of course, a portion of patients whose tumors grew despite treatment. So on this trial, there was an aggregate of 2 different cohorts, and that equaled 153 total patients that were treated with lifileucel. And 31.4% of those patients had what we call an objective response, or ORR. And that means 31 out of 100 patients had their tumors shrink or go completely away. And the disease control rate, which is essentially the stable disease, which means the disease is not progressing, the shrinkage of tumor, as well as the tumors that went completely away, that percentage is actually 77%, 77.7 or 78%. So 78 out of 100 patients treated on this trial either had their tumors be stable and not growing, shrink, or go completely away. And some of the promise here, certainly, while we wish that response rate was better than 31.4%, I think one of the real promises here that we see is over here on the right. So DOR is duration of response. And I just want to emphasize again that this is a one-time treatment. This is not something that patients are coming every few weeks to get an infusion of. And the patients in this trial that did respond had durable responses. So in this study, the median study follow-up was 36 months. And in the patients who responded, more than half of the patients had not yet reached that median. So the median duration of response was not reached. But of the responders, 42% of those patients were still responding and had not required additional treatment at the 18+ month mark. And I think that's really some of the promise of this approach and why many of us have been really excited about it, that it offers a chance for really durable treatment off of all additional therapy. The median overall survival in this trial was 14 months with a 12-month survival rate of 54%. So a lot of the questions that I've been asked about lifileucel really are, how tough is this? Or what are the side effects of this? And I see a couple of my patients on today, but I think that, and I've seen many join. And so those that have heard me talk about this have heard me say this before. But, essentially, this is a really tough 2 to 4 weeks for patients. At that point, right, many of the side effects resolve. And so what I'll mention here, right? So we have, day 0 and then day 14. And you can see there's lots of side effects, and I'll go over those in just a minute, in that first 2 weeks, right? And that is, from the chemotherapy and from the IL-2 treatment. But past that sort of day 14, day 15 mark, we see very few new side effects and very little ongoing side effects. And I think that's really the important thing. And to emphasize here that while this 2-week period is very tough, and I will not downplay that by any stretch of the imagination, this is the period of time when patients are in the hospital, they're under our full-time care, and many of these side effects are things that we know, we can predict, and we expect to happen. So first and foremost, many of the side effects are related to the chemotherapy. So you see that listed over here as hematologic lab abnormalities, right? But all of the blood counts go down. We expect that. That is in fact the goal of the chemotherapy, to cause the white blood cell count to go down basically to 0, right? That is what prepares the body to receive these T cells. So you see these, percentages in the 100% range, but again, that is completely expected. That's not an unexpected side effect. One of the complications certainly of having these low blood counts is the risk of infection goes up, and we certainly know that some patients will have fevers and even active infections during this period of time. You can see that rate here. So, 41.7% of patients had what we call febrile neutropenia, or fevers when their blood counts are down. But again, these are very common problems in oncology and happen frequently with any chemotherapy, not just with lifileucel. And so something that, many oncologists are well versed at managing. I will note, however, that platelets go down, and that does put patients at risk of infection, or of bleeding, and that is something that we need to monitor for. And many patients will need platelet transfusions at some point during this process to ensure that they're safe and protected from bleeding during this process. Additionally, unfortunately, the red blood cell count sort of gets caught in the crossfire of the chemotherapy. And there are patients who will require red blood cell transfusions as well for low red blood cell counts. IL-2 is the other portion of this, certainly, and IL-2 has its own side effects, as many of us are well aware. The most common things that we see with IL-2 are fevers and shaking chills. That happens in a large portion of patients, as you can see here. Fevers in 52% of patients, chills in 75% of patients. So quite common. We give medicines to help minimize that. So patients get Tylenol, they get medications like Demerol or morphine to help with shaking chills. But IL-2 can also cause low blood pressure. It can cause fluid to leak out into the hands or feet, and sometimes even the lungs. That can require patients to require oxygen for a portion of time. And that low blood pressure or low fluid levels can also damage the kidneys. So IL-2 needs to be managed very carefully by experienced centers. One of the things that we've learned in the last few years, and even during the course of this C-144-01 trial, was that we did not need to be as aggressive as we used to be with the IL-2. So you can see here that the median number of doses on the clinical trial was 6. And that was because at the beginning of this trial, we really felt strongly that patients needed to get all 6 doses of the IL-2 to have a chance at responding to lifileucel. And as it turns out, we've now seen data presented from this trial that suggests that patients who needed to stop the IL-2 early because of bad side effects did just as well as patients who got all 6 doses. And so we've now really toned down our approach. And when patients start to run into more challenges with the IL-2 side effects, we can simply stop it early if we need to. Okay, so let me transition a little bit to, where do we think this fits, and what do we do with patients, who have progressed on standard checkpoint blockade? What do we recommend for them? So when we look at, treatments that are available to patients that have progressed on standard checkpoint blockade, right? We have data about ipilimumab plus a PD-1 drug. So, we have the S1616 trial, as well as Dr. Daniel Olson's study about pembrolizumab plus low-dose ipilimumab. So if patients have not had CTLA-4, right, and have progressed simply on PD-1, then we know that a CTLA-4 plus PD-1 combination treatment has about a 25 to 29% response rate. And those responses can be durable. So that could be a really good option for patients who have progressed on just PD-1 alone. However, that requires long-term monitoring and long-term treatment, unlike something like a lifileucel approach. Additionally, on that C-144-01 trial, most of the patients had not only progressed on PD-1, but had also progressed on a CTLA-4 containing regimen. And so that wouldn't really have been a viable option for those particular patients. I'm asked frequently about, for patients whose melanoma has progressed on a PD-1 containing regimen, what about giving nivolumab plus relatlimab, the next most recently approved drug for metastatic melanoma? We know from the Relativity 020 trial that has only about a 12% response rate. So I don't think that is as good of an option for many of our patients. We all know that for patients who have a BRAF mutation, that targeted therapy may be a good option, and that does have good response rates. Unfortunately, the durability of those are questionable for many patients, and many patients will get a period of months to short years out of targeted therapy. But unfortunately, for most patients, at some point, the melanoma will find a way to progress past that targeted therapy. And again, lifileucel is really intended for patients that have already seen those targeted therapy medicines. And then for patients who had nivolumab plus relatlimab initially, we know that ipilimumab plus nivolumab may be an option, again, with about a 25% response rate, though we are still very much learning about that regimen and what the responses and durability of those responses may be. So I do think that lifileucel is a really, viable option for many of our patients, particularly those who have seen CTLA-4 plus PD-1, again, with a 31% response rate, and the duration of response not reached, the median duration of response not reached, but knowing that many of those patients will have durable responses who do respond. I just want to say that this is not unique, and there has been additional data that have come out about TIL cell therapy for patients with advanced melanoma. There was a trial presented in the New England Journal of Medicine that randomized patients who had progressed, whose melanoma had progressed on a PD-1 containing regimen. And patients were randomized to either TIL treatment, and this was not lifileucel, this was TIL made at a local institution, but very, very similar process. Versus randomizing those patients to ipilimumab. And we can see here, so this is progression-free survival, and this is essentially proportions of patients. So the higher up on the curve, the better patients did overall. And you can see here that the average or the curve here for TIL cell therapy looks much better than ipilimumab alone. And when we look at the medians here, so the median progression-free survival for the TIL group was 7.2 months versus only 3.1 months for ipilimumab alone. Additionally, if we look at just the response rate, it was actually much higher in this trial. So up to 49% of patients responding to TIL cell therapy in this trial, compared to 21% with ipilimumab. And up to 20% of the patients on this trial actually had a complete response or had all of their melanoma go away. And I think some of the difference here, there are differences between these patient populations, but one of them is that the patients included in this particular trial had only had one line of prior therapy, had only had a PD-1 drug prior to this. And so I do think this speaks to the importance of patients being referred early after progression on a PD-1 containing regimen, that there really may be better outcomes, and certainly patients seem to tolerate this regimen better the earlier they are treated with TIL cells. Certainly, as we said before, this is a toxic treatment. We all know that there are significant side effects to TIL cell therapy, and you will hear from our patient in a little bit about his experience, which I think will be really important to hear about. But this study did something that I think was very critical and looked at health-related quality of life 6 months after treatment. So not necessarily what was that 1 month of treatment like, but what did a patient's life look like 6 months later? And when compared to patients who received ipilimumab, patients in the TIL group had better quality of life, better physical functioning, better emotional functioning, and significantly less of many of these symptoms that were assessed on, validated measures of patient outcomes. And so I think when we look beyond just that 1 month of treatment, the data really do speak to how well patients can do long-term with TIL cell treatment. So all of that is to say that the era of TIL therapy is finally here. The FDA approved lifileucel on February 16th of this year, and we're really excited that it is here. We are actively treating patients. And so this is our team here at Stanford doing a surgery for one of our first patients, 4 days after the FDA approval. This is our surgeon, Dr. Amanda Karani, our nurse coordinator, Laura Morris, and myself, heading in to do the surgery on this first patient, as well as members of our cell therapy facility. So who is this the right treatment for? There are many patients for, lots of questions around this, and we'll be happy to answer some at the end as well. I've tried to capture some of it on this slide and the next as well. But first and foremost, this is not for uveal melanoma yet. So the FDA approval is for non-uveal melanoma, meaning that we can treat patients with cutaneous melanoma, mucosal melanoma, acral melanoma, and melanoma of unknown primary. TIL for uveal melanoma is still being studied in clinical trials, but is not yet available under the FDA approval. Patients are required to have had tumor that grew despite immunotherapy containing PD-1 in the past. And if patients have a BRAF mutation, their tumor is required to have grown after treatment with targeted therapy as well. Do need to have relatively slow growing disease, right? So as I mentioned, there is that production period of time, and that period of time between the surgery and when we will get the cells back and be able to begin the treatment. And that period of time is about 35 days. While some treatment can be given during that time, patients who have rapidly growing disease, unfortunately, just aren't a candidate for this therapy yet. We do need to have 1.5 to 4 centimeters of tumor that can be taken out to actually make the lifileucel product, and then additional disease after that that is available to be treated and to trigger that immune response. Additionally, patients need to have what we call good performance status. So for example, need to be able to walk around the block, take care of themselves, do things like light housework or office work. Unfortunately, I know there are many patients out there who are interested in this therapy who, are not able to do those things, who are wheelchair bound. And unfortunately, this therapy is not quite ready for those patients yet. It is still, a challenging therapy. And so we really do need patients to be able to do that type of thing, to be able to safely give them lifileucel. Normal or near normal heart, lung, kidney, and liver function. And all of that is needed to be able to safely get the chemotherapy as well as the IL-2 portion of the treatment. And so not requiring oxygen at baseline is one of the very key criteria for eligibility for TIL. As of right now, we don't know about the safety of treating patients who have active or untreated brain metastases. And this has been a really common question that we've been asked. So any prior brain metastases must be treated and must not grow or recur for a period of about 4 weeks before a patient will be considered eligible for TIL. And that is based on the safety that we know of from the clinical trials. There are clinical trials ongoing that do look at TIL for active brain metastases, but we are making specific considerations for those patients and changing the regimen a bit to ensure that this is safe. Patients can't be on steroids. So patients who have a history of hypophysitis or adrenal insufficiency from prior checkpoint, if they're on just a replacement dose, that's okay. But patients who require steroids either for brain metastasis or from symptoms from, checkpoint blockade or toxicity from prior immunotherapy, unfortunately are not eligible for TIL until they've been off steroids or other immunosuppression for about 30 days. And that's because those steroids and immunosuppression actually harm the T cells that we are trying to take out. And if we don't take out good T cells, we can't make a good T cell product. And then the last piece of this is patients can't have active or ongoing infections because we are going to give chemotherapy and knock the immune system down so significantly. That would be very, very risky to do in patients who have active infections. So access, how do patients get access to lifileucel? So patients need to be referred to what is called an authorized treatment center. There are certain centers who have gone through specific training and been qualified to give lifileucel. Those can be found on this website, which is the drug website, by searching by area code or zip code or just the city that the patient is in to find the closest authorized treatment center. Prior to either being referred or during that process, patients will need up-to-date scans, including imaging of the brain to ensure that there are no active brain metastases. An ultrasound of the heart or echocardiogram to ensure that the heart function is appropriate. Labs to make sure that the liver and kidney function as well as blood counts are appropriate. And some patients will need tests of their lung function. So patients who have a history of pneumonitis from either prior therapy or prior infection, patients who have a history of smoking, a heavy history of smoking, asthma, COPD, emphysema, or any other really lung issue will need to pass certain levels of lung functioning. And then after referral to the authorized treatment center, more testing will be needed, special viral labs and other things that will be specific to particular patients. There's a lot of guidance out there. This is a paper that we published. I was the lead author of this paper with our TIL working group, which is an international group of experts who have been giving TIL therapy. That is really a consensus statement of all of the things that I just covered. Who are the appropriate patients? How can we do this safely? All of the, for anyone working at a center here that is considering giving TIL therapy, how do you set up a program for this? All of that is available here in this paper, and I do think it can be helpful. And I know several of my patients and their caregivers have also read this to get a little bit more information about the process, though certainly this is written more for physicians and medical teams than it is particularly aimed at patients. In conclusion, I will say that TIL therapy is finally here for advanced melanoma. Many of us are here. We are giving lifileucel, and we're very happy to be able to do that. This offers a one-time therapy treatment option for patients. While that toxicity is significant during that period of time, it is typically short-lived. We are getting much better at managing it. And the data suggests that long-term quality of life really is excellent for patients who respond. And that lifileucel and clinical trials for other TIL options are available for melanoma and beyond, and really encouraging patients to ask their healthcare providers about this, and for physicians at centers who do not have TIL available to be sure to refer patients early for consideration of this treatment. And with that, I will stop sharing and turn it back to the MRF team.
Thank you so much, Dr. Beitoff. That was amazing. Next, we are going to hear from melanoma survivor and patient advocate, Jamie Tomasco. Jamie lives in Tampa, Florida with his wife, Angie, and they have one son, Eric, a wonderful daughter-in-law, Amy, and a beautiful 14-year-old granddaughter. Jamie had surgery to remove melanoma from his back in 2012 and was diagnosed with stage 4B metastatic melanoma in 2014. He was accepted to the stage 2 TIL trial at Moffitt Cancer Center in Tampa, Florida. Jamie's tumors continue to recede and grow smaller, and some have completely disappeared with nothing left but scar tissue. He has not had a bad checkup since he started TIL trial in 2014. Jamie credits TIL, the incredible staff at Moffitt, and his wonderful family for saving his life. Jamie, take it over.
First of all, doctor, thank you so much for all of your work. I loved listening to yours. The cancer treatment was very easy for me. There was a couple of rough times, but all of the staff prepared me well for it. It was amazing. I was only in the hospital maybe 6 or 7 days, I would say. I took some notes. It's been 9 years, so when I go to Moffitt, I'm not worried at all anymore on my scans. I can tell that I'm cancer free in my mind. The TIL worked amazing for me. The hardest part was for me was the chemotherapy. It was, but I still worked through the whole chemo. The last 3 days of chemo, going as an outpatient, and then 2 days in the hospital. And then I went home for a couple of days, and then I went for the TIL trial. It was amazing. The hospital stay was maybe 6 days, and the TIL, you don't even know it's happening. It's just like giving blood or taking blood. But the IL-2 was a little rough, and I received 4 treatments, and they stopped because my heart rate went too high. But it still was not. They gave me morphine when I had chills. They had every kind of medicine you could ask for anything that happened to you while you're in the hospital. And they gave you complete confidence while you're in there that they're going to be able to handle anything that comes up, and they did. I don't worry about melanoma anymore at all because of TIL. And when I was diagnosed, I had never even heard of metastatic melanoma, and it changed my life overnight until TIL. TIL was I only had a couple of options. I was not BRAF mutant, or I'm not sure the term, but I didn't have those options. So TIL was the best one for me, and it worked. I thank God for all of the work they have done. It was amazing. I wrote a note that I grew 92 billion cells in 35 days. So my T cells responded very well to the medicine they were giving me. It was only, and it's you think it's maybe 1 month out of your life that's uncomfortable, and I've had 9 years so far with no problems whatsoever. I go once a year now for a scan, and it's been perfect every time. I don't have anything to complain about. We're just lucky to be around at this time. 15 years ago, we wouldn't have these options. Even 10 years ago, that was only the second part of the trial. And it worked out very well. I am so glad. I'm hoping that the TIL works for all the other cancers. Eventually, they get that for all the cancers that are tumors. Save a lot of lives. As long as we have doctors like her working for us, we're in good shape. Thank you.
Thank you, Jamie. Thank you so much. Now we're going to go into our Q&A portion. And so we have a few questions. Please keep sending in the questions. This one is for Dr. Batoff. Taking into consideration that part of the melanoma treatment is having TIL cells extracted from patient tumor growing, rejuvenating ex vivo, and part of the process is feeding TIL cells with healthy donor irradiated feeder T cells, what is the chance of the patient to develop immunoreaction rejection due to recipient's antibodies not recognizing proteins from donors' lymphocytes? Could a lymphocyte cross-matching test be an alternative to avoid that?
Yeah, that's a great question. I'm going to come back to it in 1 second. I just want to take a second and just say thank you to Jamie. I mean, your voice is so powerful here, much more than anything I could say. And I'm just thrilled to see you doing beautifully 9 years later after TIL treatment. It's just really incredible. So I want to say thank you for taking the time to do this, and to offering hope to a bunch of patients and their caregivers who are going to watch this, because I think it's really important. So to come back to your question, it's a great question about essentially whether the feeder T cells that we use to stimulate this growth could trigger an immune response. And while, I would say, I guess in theory, it's possible. That isn't something we have ever seen, at least on this trial and to my knowledge. So these cells are sorted after, and they are quite careful, obviously, to maintain the patient's cells and getting, no cross matching and no outside antigens coming in. But while I do think, I guess in theory that is possible, it's just not something that we have seen, including, beyond just the 153 patients on the C-144-01 trial, but additionally in the Netherlands Cancer Institute trial, and in the many years that this has been done in other trials, as well as at the National Cancer Institute. And so, I think we will continue to refine the process of expanding these cells. That in particular, this sort of, cross-antigen presentation issue, I don't think is one that we, are actively tackling, because I have not seen that be an issue.
Thank you. We have another question about if T cells are being engineered to enhance them, can it be done effectively with lower quality T cells? What is the likely quality of T cells from patients who have had immunotherapy and had partial or no responses? And can SUV read determine tumor viability?
Yeah, it's a great question. I think we are actively trying to learn, what makes good TIL versus quote unquote bad TIL, or TIL that people are less likely to respond to. Patients who have progressed and had no response to checkpoint blockade absolutely respond to TIL. And many of my patients, that had primary refractory disease, meaning they never had a response to checkpoint blockade, have had a response to TIL. So just because those T cells did not respond to, checkpoint blockade or standard immunotherapy does not mean that those TILs won't work to kill melanoma when given as a TIL therapy. And I think there are many reasons for that, but one of them, and maybe the simplest way to think about this, is a sheer numbers game. Jamie told you he got 92,000 or 92 billion, I think was the number he quoted, right? But we are looking for and searching to expand something, in the billions of cells, so 7.5 to 100 billion T cells. And so, overpowering the tumor with just more of these, tumor recognizing T cells may be the answer there. In terms of picking the best site from where to, take out a piece of tumor, SUV on a PET scan is one way to look at this. And there's actually several publications out there about how to pick the best site. Again, something we are learning about. What I would say is, you want to choose a place that has, viable tumor, so tumor that is alive, rather than dead tumor, because that is more likely to give you active T cells. Ideally, we would like tumors that have not received radiation, because we think that will give healthier T cells, but we can use tumors that have had radiation that have grown past or after that radiation treatment, and that has made TILs that people have responded to. So I think some of these questions are really good ones, but something we're going to learn more about as we treat more and more patients, right? When we are trying to subset out, the patients who respond versus the patients whose tumor did not respond, and you're only talking about a total of 153 patients, right? We start, maybe jumping to early conclusions. I think as we start treating hundreds of patients and hopefully into the thousands of patients, as we have with, standard immunotherapy, we will start to really be able to get a better feel about this, of what sites make the best TIL, whether we can use whether we can use PET scans and SUV as a way to, predict the best site. But right now, I think all of that is, what we call hypothesis generating, or something that we think makes sense, but isn't necessarily bearing out in clinical practice until we just see more numbers.
Thank you. And we have a lot of questions coming in, and I think you actually answered 2 of them, which is great.
Okay.
So, and I just want to remind people, we have Jamie here as well. So you're welcome to ask him questions as well about his experience. Our next question is, why is lymphodepletion required?
Great question. So lymphodepletion is the chemotherapy part of this. And essentially, there were studies that tried to leave this out, and this just doesn't work as well. So your natural immune system has both cells that tell the immune system to be more active, right, to step on the gas of the immune system, as well as suppressive cells, right? And that's natural, right? We're trying to keep our immune system in a normal balance. Part of the goal of the lymphodepletion is to get rid of many, if not as many as possible, of those suppressive cells, so that we get more of the go signal for the immune system. We don't want suppressive cells competing with the TIL cells that we're going to give to a patient, because we want the maximum, immune response that we can get for that period of time. After, that, initial period where the blood counts come down, they will come back, and that will that will include some suppressive cells. So you will regain that balance of the immune system. But when we're trying to get our maximal response, we want to get rid of all of those suppressive signals so that the immune system can be, and those TILs can be, as effective as possible.
See our next question. How is adequate active tumor burden measured?
Yeah, it's a good question. Certainly you need the 1.5 to 4 centimeters of tumor to make the TIL, that we can take out to make the TIL. Whether TIL can or should be given to patients who don't have residual tumor after that, I think, is a very open question. The TIL cells need, or at least we think, need some tumor antigen, right? The thing the immune system sees to trigger that response and to keep those cells going. And so giving TILs when there's no active tumor is just something we don't know about. It might work, but that really requires a clinical trial to demonstrate. And what I would hate to do is to put someone through all of this and not know if there's any potential benefit, right? And so I think it's really important that we not, just because this treatment is available doesn't mean it's the right thing for everyone. We really need to give it when it is appropriate and when we know there's a chance for patients to benefit. But, there's risk associated with this, the bleeding, the infection, other things that we talked about. And so, I think it's important whenever we give a treatment that we think about what the chance of benefiting is and weigh that against the risk of the treatment. And right now, if all of the tumor is taken out, we really don't know what the potential benefit is. That has not been studied.
Got a lot of questions coming in, guys. Okay, this one is for Jamie. Jamie, tell us a little bit more about your experience at the forefront of this groundbreaking treatment and how you felt, being at the forefront of it.
It was amazing. I mean, it was very nerve-wracking. I had, I don't think I ever got a count of how many tumors I really had. It was in all of my organs. So that part was panicking, but the doctors put me at very good ease. They had a lot of confidence in this TIL trial, and it was amazing. And I probably downplay how that it's a little harsh because it was for such a short period of time of feeling bad to not worry about it anymore. The checkups just got better, better and better and better every time. I never had any more medicine. I took all the side effect medicines were gone within 2 weeks. I was just back to my, it took a while to get your strength back, but it's very quickly. It's very quick. It is, and it's a great feeling, amazing, especially when 2 months before that, you didn't think there was any hope. It happened very quickly.
Thank you. Thank you for sharing that. God, another question about this is an interesting. After extracting the tumor to grow the T cells, is it possible that the T cells fail to grow in the lab? And if it is possible that the T cells fail to grow in the lab, could the procedure to take out the tumor to grow T cells be repeated?
Yeah, it is possible. It used to happen, pre-lifileucel, when this was still a very experimental early treatment in the late, 1980s, 1990s at the National Cancer Institute, used to happen more frequently. And I know there are some patients who are well versed in this field that have heard that. And so I think it's important to acknowledge. On the clinical trials of lifileucel and similar trials, that rate where patients undergo a surgery and do not make, TIL that can be infused is much, much lower. It's about 96% of patients who underwent a surgery made TIL product that was, appropriate for infusion. Certainly, I do think it is possible if a patient's, underwent a surgery and did not make TIL, if they were still, healthy and appropriate for treatment, I do think it might be possible to undergo a second surgery. But those I think would be case by case evaluations of understanding why the TIL maybe didn't grow. Was there something unique about a particular tumor that a different site might be better, et cetera, et cetera. I think those are, individual situations that a patient's healthcare team would need to take, into consideration. But technically, yes, it could be done again.
So that was a great question. What could patients actively do to be in the best position to have successful outcomes?
Yeah, great question. I think probably the best things that a patient can do, one is listen and have good dialogue with their healthcare team. Every patient is coming into this with a unique situation, whatever it is. And, there may be unique aspects of their care that, need to be considered. That being said, sort of across the board, eating well, by which I mean good nutrient dense foods, making sure that they are maintaining their body weight and not losing weight going into this, exercising, and being able to maintain that good functional status. The stronger you go into this, the easier this process will be, right? Everyone, as you heard Jamie say, will get knocked down to some degree with the chemotherapy and the IL-2. There's no question about it. And so, if you can start up here, your recovery will be much easier than if you're starting already going in a bit more frail. So eating well, sleeping well, exercising, all the things that, we encourage our patients to do at any stage of treatment, I think is very, very important in preparation for TIL.
Okay, we have a few minutes left. So if you do have questions, keep them coming in. We still have some, but I want to just make sure we get your questions. Can a patient be a candidate for TIL if they have had an experimental viral therapy?
Yeah, absolutely. There's lifileucel, right, the approved drug, and then there are also clinical trials of TIL. Some clinical trials may have more limitations about what a patient can have had prior to going on a clinical trial. Every clinical trial is different. For the approved drug, absolutely, as long as the patient is, fully recovered from whatever their prior treatment was, not on steroids and meets those other criteria that we discussed, you know, and any type of prior therapy, viral therapy, you know, other experimental therapy absolutely could be, you know, patients could be considered for TIL.
Thank you. Another question for Jamie. Jamie, is there any advice you'd like to give other patients that are considering this therapy?
I would say exactly what the doctor said. The whole time I wasn't sure if I was going to get well or not. All I tried to do was to go to work as much as I could when I was able, and exercise, eat right. I think the best chance anyone has to fight this is, of course, with these doctors that are the smartest people in the world, and staying healthy so your body can take these treatments and keep a good attitude. You know, don't let it stress you out where you have all the, because it is what it is. Just do the best you can and stay healthy as much as you can.
Great advice. Thank you.
Yeah, I
Thank
want to
you.
emphasize two things. So one is like, you know, when we say exercise, and Jamie mentioned this too, I mean, we're not necessarily talking about going to the gym or lifting weights or running a marathon, right? Going for a walk every day. Even if that's a 10-minute walk and you're building your way up to a 15-minute walk, right? And really trying to just slowly move that needle up, right? For many cancer patients, that is more than sufficient. And so I know sometimes patients hear exercise and they're like, you know, how do you think I could possibly go to the gym on top of all of this? And I just want to emphasize that, you know, walking in your own home, around your own block, all of those things, right? That those are equally as important as any of those things. And, you know, I think especially kudos to Jamie for going to work. I think sometimes patients actually find a lot of benefit to maintaining, whether maybe it's not full-time work, but some type of work, or even volunteering, just to, you know, kind of, as Jamie said, keep your mind off of this. You know, being 100% fixated on your treatment all the time isn't necessarily, that's your doctor's job. You know, my patients hear me joke all the time that they pay me to do the worrying. You know, and while, you know, I say that tongue in cheek, and I know that patients and their caregivers worry, I do think there's real benefit to trying to maintain, you know, as normal a life and your best quality of life that you can.
Well, thank you for that. And as you can see, we're kind of close to time, so I think we're gonna leave it there. We do have a few more little questions, and I'll try to get those answered for you guys and then send them to you. Just want to I just would like to thank all of you for joining us today, especially our speakers for presenting today during the Ask the Expert session. We appreciate all that you do for the melanoma community, and appreciate you taking additional time to be with us this evening. Thank you again to Iovance for their generous support of our Ask the Expert webinar series. Again, this program will be available on demand on our learning platform, and also streamed on our social media channels. And I just want to click here. These are our social media channels if you'd like to follow us. At the end of the program, when you close your screen, there will be a short evaluation that will pop up in your browser. Please fill that out. It provides us with feedback on today's session and helps us create new programs for the future. Please visit melanoma.org to learn more about our upcoming webinars and other educational or advocacy opportunities. We have a ton of free educational resources that we offer to patients, caregivers, and healthcare providers, including educational literature, a patient forum, Ask the Nurse email, and an animated patient video series. And if you're interested in learning more about TIL cell therapy, please check out our Learning Institute, which includes a one-page infographic and a 7-minute animated video all about TIL cell therapy for melanoma. Just to note, this video is currently being updated to reflect the February 2024 FDA approval, but be sure to check back soon for the updated video. And you can find that at in our Educational Institute. If you have any questions that you think of later, just please email us at education@melanoma.org. And thank you again for joining us today. And thank you again to our speakers, Dr. Batoff, Jamie, and Vanita. Thank you so much as well. And I hope you guys have a good night.